Welcome to this high-yield explainer. Today, we're cutting straight through those dense clinical notes to pull out the exact exam-crushing facts you need. Infectious arthritis is honestly one of the most heavily tested, high-stakes topics you're going to encounter. So we're breaking down exactly what you need to know, stripping away all the fluff and focusing on exactly what drives correct diagnoses and ultimately saves your patient's joints. Let's get into it. Okay, so here's our game plan for today. We'll be moving through diagnosis and synovial fluid, high-yield microbiology, non-gonococcal treatment, gonococcal versus DGI, specialized arthritis, and finally, prosthetic joints. Starting off with Section 1, diagnosis and synovial fluid. We absolutely have to evaluate these cases without delay.
48 hours. This right here is your ticking clock. Cartilage destruction literally begins within 48 hours. Why? Well, it's a mix of skyrocketing intra-articular pressure, proteases, and direct bacterial invasion. You see, when bacteria escape the synovial capillaries, which, remember, completely lack a basement membrane, neutrophilic infiltration kicks in within hours. Chondrocytes and macrophages just flood the joint with cytokines. If we don't act fast, we're looking at permanent cartilage breakdown, and later on, nasty pannus formation and vessel thrombosis.
Now, you've got to sear this number into your brain. 100,000. That is the average synovial white blood cell count for acute bacterial septic arthritis. Sure, in the real world, the range might sit anywhere between 25,000 and 250,000, but 100,000 is your classic anchor number. It's the exact threshold you're looking for in any patient vignette describing a turbid or purulent joint aspirate. When you compare the different conditions, look at the massive jump in acute bacterial infections. We're talking a polymorphonuclear percentage of 90 or more. But then DGI sits shockingly low, usually just 10 to 20,000. Also, keep in mind that crystal-induced or rheumatoid arthritis typically presents with much lower counts, generally under 50,000. Keeping these distinct ranges in mind is basically your cheat sheet for rapid differential diagnosis. Okay, time for a massive exam pearl. Do not, I repeat, do not trust a negative gram stain to rule out an infection. A gram stain is only going to catch the pathogen maybe 30 to 50% of the time. But synovial fluid culture, that comes back positive in over 90% of non-gonococcal bacterial arthritis cases. Oh, and another crucial rule, never ever instill antibiotics directly into the joint space. Systemic IV delivery is the gold standard and achieves perfectly adequate synovial fluid levels. Moving right along to Section 2. High-yield microbiology. Let's talk pathogens by age and risk. So the huge takeaway here is that while Staph aureus dominates almost universally across children and adults, you have to watch out for the exceptions. Group B strep absolutely rules neonates. And Neisseria gonorrhea, that is the most common culprit in sexually active young adults under 40. Also, just a quick aside, remember that Staph aureus is the primary threat for rheumatoid arthritis patients, mostly because of their inflamed joints, skin breakdown, and of course their glucocorticoid use. Now let's play a quick game of word association, because board exams absolutely love these rote memorization triggers. If a question mentions a shoe puncture through the foot, you immediately select Pseudomonas aeruginosa. An animal bite, Pasteurella multicida. Human bite, Eikenella corrodens. And for IV drug users, definitely watch out for Staph aureus and Pseudomonas, but pay close attention to the location. They preferentially get infections in the spine, sacroiliac, and sternoclavicular joints, way more than the standard appendicular skeleton. Let's jump into Section 3, non-gonococcal treatment. It's all about aggressive management. Your empirical treatment plan relies entirely on what that initial gram stain shows. If the smear shows gram-positive cocci, boom, we immediately start IV vancomycin. If it's gram-negative bacilli without any Pseudomonas risk, go straight to cefotaxime or ceftriaxone. You only step up to a heavy hitter like cefepime or ceftazidime when Pseudomonas risk is actually present. And ultimately, if it's Staph aureus, you're locked in for a full 4 weeks of definitive therapy. If you ever get tested on the drainage order, the rule of thumb is to always start with needle aspiration. But there is one glaring exception you must memorize: hip septic arthritis. That requires an immediate open arthrotomy to save the viability of the femoral head, especially in young children. Otherwise, the standard progression is needle aspiration first, stepping up to arthroscopic lavage if that fails after a few days, and finally arthrotomy if you really have to. And hey, while passive motion is great for recovery, make sure they avoid weight bearing until the inflammation is totally gone. Section 4, gonococcal versus DGI. Let's look at the distinguishing features. Test writers love to hammer this differential. DGI is a migratory immune complex syndrome. It's got those surprisingly low synovial white counts we talked about, prominent tenosynovitis, and those classic hemorrhagic pustules on the trunk and extensor surfaces. True gonococcal arthritis, on the other hand, it settles right into a single joint with explosive white counts and absolutely no rash. In fact, true GC arthritis almost always follows an unrecognized DGI phase. Okay, here are your rapid-fire DGI pearls to lock in. Look for female patients, particularly during menses or pregnancy. They're 2 to 3 times more likely to get this. Test for terminal complement deficiency if you're seeing recurrent Neisseria infections. And you've got to culture directly onto Thayer Martin agar with 5% CO2 right at the bedside. Why? Because the synovial fluid cultures in DGI are almost always negative. You have to swab mucosal sites like the endocervix or urethra. Finally, if you see a dramatic clinical improvement within 12 to 24 hours of starting ceftriaxone, that is your diagnostic slam dunk. Moving on to Section 5, Specialized Arthritis. We're looking at Lyme, TB, and reactive arthritis. Pay really close attention to the timeline clues in your exam vignettes here. Lyme arthritis waxes and wanes intermittently, often showing up as a monoarthritis of the knee in untreated patients. TB arthritis, though, that is a slow, chronic burn. It happens over months or even years, creating a granulomatous monoarthritis, usually in your large weight-bearing joints. And, fun fact, having coexistent pulmonary TB at the same time is actually pretty rare. When it comes to reactive arthritis, the classic writer's triad is your best friend: urethritis, conjunctivitis, and arthritis. It's strongly associated with the HLA-B27 genetic factor and is usually triggered by a recent chlamydia or enteric infection. Keep your eyes peeled for young men presenting with painful, asymmetric oligoarthritis. Think knees, ankles, or feet a few weeks after a GI bug like salmonella or chlamydia. Most will recover within 6 months, but recurrent disease happens a lot. Finally, Section 6, Prosthetic Joints. Let's talk about these mechanical nightmares. Before we break down the treatment protocol, let's do a quick knowledge check. Out of all the major joint replacements, which one statistically causes the absolute most headaches when it comes to infectious arthritis? Any guesses? The answer is the knee. It suffers a surprisingly notable 0.5% to 2% infection incidence rate, making it statistically much more vulnerable than the hip. Your exams are going to divide these infections into 2 very distinct phases. First, you have your early acute infections. These are usually caused by intraoperative Staph aureus and show up with obvious fever and severe local inflammation. Then you have the late infections. These are sneaky. They're indolent, usually driven by organisms like coagulase-negative staph or Cutibacterium. You'll definitely see an elevated ESR and CRP, but the patient might just come in complaining of chronic, unexplained pain and a loosening prosthesis. For diagnosis, remember the buzzword sonication. It literally breaks up the bacterial biofilm on the explanted prosthesis to vastly improve your culture yield, which is super helpful if the patient was already on antibiotics. And honestly, brace yourself for the management reality here. Treating this almost always requires total removal of the prosthesis, plus 4 to 6 weeks of parental antibiotics, because the bone itself is involved. Reimplantation is delayed for weeks or even months, and unfortunately, relapses are super common. So as we wrap up this explainer, I want to leave you with this final critical thought. When that clock starts ticking on joint inflammation, will your rapid recall be fast enough to save your patient's mobility? By keeping that critical 48-hour window and these high-yield pathogens front and center in your mind, you're not just ready to crush your exams. You're ready to be the decisive clinician your patients desperately need. Thanks for joining me.